Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome to Airway Answers. I am here with two wonderful superstars who I am just so happy that you guys are giving your time to help educate everybody about what you do. I have Dr. Michael Gunson and Dr. Rebecca Bockow here, and I'm sure everybody already knows who you are, but thank you so much for being here. I really appreciate it. So what we're going to do. Can we hear you guys? Good. Let me.
Happy New Year.
Happy New Year to everybody. Yes. So I'm sure everybody knows who both of you are, but I'm going to do a bio and then we'll get chatting. No worries. We have puppies and dogs in the background, so no problem at all. I'll show my new little puppy because I got to hold her up. I just got a puppy a couple days ago, so this is Coco. Yeah. So hopefully she'll sleep the whole time. And then you, Dr. Bockow has the same 𝐃𝐈𝐒𝐂𝐋𝐀 dog as well. So fun. Okay, so I'm going to introduce you guys, talk about your background, and then we'll get into a bunch of different airway questions that I have. So we'll start with Dr. Michael Gunson, who is a board certified oral and maxillofacial surgeon and practices in Santa Barbara, California. Beautiful office, beautiful location. When I go, it's like a vacation to probably live in Santa Barbara, I think. When I drove there from San Diego, it's like all of a sudden just like palm trees and blue water. It's a beautiful drive. So that's a great place to be. Dr. Gunson graduated from UCLA Dental School and Medical School and received his specialty certificate in oral and maxillofacial surgery from UCLA. Dr. Gunson partnered with Dr. G. William Arnett at the Center for Corrective Jaw Surgery in Santa Barbara, California. Their surgical practice has always been limited to diagnosing and treating facial growth problems by performing corrective jaw surgeries. Dr. Gunson is passionate about facial aesthetics and facial function. He believes they go hand in hand, and he diagnoses and treats patients with facial and dental aesthetic concerns, difficulty with chewing and speech, and sleep apnea. Dr. Gunson's orthognathic and aesthetic surgical techniques provide accurate, beautiful, and functional results that improve patient health and satisfaction. He's also an associate professor at Boston University School of Dentistry, a resident faculty at Spear Education, and a member of many dental professional groups. Dr. Gunson has hospital privileges at Goleta Valley Cottage Hospital and Santa Barbara Cottage Hospital. Dr. Gunson enjoys teaching and lecturing throughout the world and publishing research on orthognathic surgery, facial function, dental and facial aesthetics, obstructive sleep apnea, and the treatment of TMJ arthritis and condylar resorption. And I also love to hear the fun part that, excuse me, you have your wife and 3 children that you enjoy to go skiing with. So you're a skier. You love serving the community, reading, and speaking in French. I didn't know you speak French. That's pretty cool. And researching ancient Near Eastern religions and practices. And you were a philosophy major, Dr. Gunson, is that correct?
French lit, actually.
French lit. Was there something with philosophy you did? You're very philosophical. I remember last time I spoke with you. Was there anything philosophy-wise?
No, I mean, we studied the French philosophers and writers, and so, yeah.
Okay, interesting. All right. Well, thank you so much for being here. And I also have Dr. Rebecca Bockow, who is a dual-trained orthodontist and periodontist. In fact, the only dual-trained provider in Seattle and one of only a handful in the country. She grew up in the greater Seattle area and attended University Prep School for high school and received a BS in biology with honors at Haverford College, where she also enjoyed playing soccer. This is fun. Soccer. I love soccer. Squash, tennis, and you ran cross country and track. Quite an athlete. That's very great. She also completed her dental training at the University of Washington Dental School in 2007, practiced as a general dentist in Seattle for 2 years while simultaneously teaching at UW Dental School. Dr. Bockow completed a highly selective dual specialty program combining orthodontics and periodontics at the University of Pennsylvania. She's also board certified in both orthodontics and as a periodontist. And also, while simultaneously enrolled in 2 residency programs, you received a master's in oral biology focusing on intranasal ketorolac for postoperative implant pain management. Did I say that correctly?
Pretty good.
Dr. Baca also lectures nationally on periodontics, orthodontics, interdisciplinary orthodontics, airway, and skeletal growth and development, and contributes to multiple professional journals as an author and editor, and is also, like Dr. Gunson, resident faculty at Spear Education. And I wrote down some of the lectures that you've done. The way we breathe influences facial growth and development, which I want to talk about that, how the way we breathe impacts the way our facial bones grow. You've done lectures on the transverse dimension, the orthodontist role in pediatric and adult airway and sleep disorders. And also, we're going to talk about the article that you wrote along with Dr. Yoon and others, the impact of rapid palatal expansion on the size of adenoids and tonsils in children. So again, I appreciate both of you donating your time to help teach everybody about what you do. And I'm really curious the role of the dual role of the orthodontist and the oral maxillofacial surgeon and how you work together as well. So that's something I'd like to talk about. But let's start out by seeing how both of you got started in your respective fields. So how did you get interested in dentistry, orthodontics, and for Dr. Gunson, the oral maxillofacial surgery? This, and then on top of that, thinking from an airway perspective, because I know that isn't always part of an initial program. Dr. Baca, do you want to go first, talking about how you got started?
Sure. As a restorative dentist, a lot of the breakdown I saw, and many of the listeners maybe have seen this as well. To me, a lot of the breakdown we see in the adult patient is because the foundation is in the wrong place. And I thought, and there's so much history of interdisciplinary dentistry in the Seattle area. So my mentors were Frank Spear and the original interdisciplinary team with Vince Kokich and Dave Matthews, and some other big heroes here in the Seattle area, really teaching interdisciplinary care at when I was very highly influenced. Even Seattle Study Club and some other big influences to me, just getting started in my career. And so I thought, if I could get the foundation right, the bones and the teeth, then that was the role I wanted to play on the interdisciplinary team. So that was really my goal, going to pursue perio-ortho. In our program, Dr. Slick Van Arsdale was our chairman, and he believed so strongly in correcting the transverse dimension at an early age. And he didn't have the understanding that we have today about tongue space and sleep and airway. For him, it was, if we can expand early, we keep the teeth in the bone, therefore we avoid gum recession. It was all about gum recession. And so he was a huge advocate for early expansion. And here we were, residents, seeing his cases that he expanded at 5, 6, 7 and watching them grow, and just seeing these beautiful arches in these older patients into their teens and 20s. So we started using TAD expanders in 2007, 2008, 2009. We were using them in our program very early on, but it was a very different design than what we're doing today, because he thought, my gosh, if you can expand a teenager without SARPI, that's the coolest thing. So that was sort of in my mind. And then I heard Jeff Rouse speak in 2013, and I went to a 3-day seminar he gave on airway prosthodontics. And I sat in the front row, and I'm watching all these adults that have sleep apnea. And I said, those are orthodontic patients, and those are surgical patients. And those are narrow arches. Those are deficient arches. These are things that I am used to treating for kids and adults. And it was a deep dive for me. And it was really going down a rabbit hole. But at the time, there wasn't a lot of literature in the orthodontic journals, but there was literature in sleep journals and ENT journals. And so it really changed the way I looked at patients. It changed the way I started treatment planning.
Wow. And you started seeing, wait, these adults, if we can correct the foundation in an adult. It's just like what you're doing in children and using the tab expansion.
Oh, well, so for the children, it's guiding growth, and for adults, it's putting the pieces in the right place, in a healthy place.
Yeah.
And then I will turn it over to Mike, who can talk more about that.
Right. So that's interesting. I love the path you took there. That was awesome. It reminded me of when, so, you know, in oral surgery, it's unless you're taking out wisdom teeth, almost everything you do is interdisciplinary, from implants to orthognathic surgery, and reconstruction. So being an interdisciplinary like dentist is forced on you in many ways. And I always like that. I like the broad thinking, like you brought up with my background. I like literature. I like science. So what happened is when I was in medical school, I was really excited about Airway, and when I was on the ENT service, at the end of the ENT service time, you have to present papers and some ideas. So we all get together with faculty and the residents, and the medical students present the papers. So I presented Powell and Riley's papers on maxillomandibular advancement and airway and sleep apnea. And I was telling them, 90% cure rates, I'm not cure rates, but success rates, and, 50+% cure rates. And it was really interesting to see the ENT folks, their broad answer at that presentation was, that's not true. So it was kind of fun to be told that, that the data and the research was not true. But it helped open my eyes to, like, what are the biases? Why would ENTs say such things? Like, what's the data really say? And so ever since then, I've been interested in it. When I came to Santa Barbara in 2003, I had you're trying to establish your practice and get known. And so I would go from dental office to dental office, kind of sharing lectures on sleep apnea and how the dentist could identify this in kids and make the appropriate referrals. And so it's always been important and exciting. Plus, I very much have enjoyed the robust research that's been done in those areas. Very scientific and very helpful in leading us to solving problems for kids and adults.
So I always find it interesting that not all oral maxillofacial surgeons think from an airway perspective. And we know same thing in the orthodontic field. A lot of it is more cosmetic approach. So how did you both begin to think from thinking about breathing and sleep and airway versus just looking at tooth alignment and just solely focusing on the aesthetic component of the work that you do?
Is that for me?
Sure.
Both. Whoever feels the urge. You want to go first, Rebecca?
I'll let you go first, Mike.
Okay.
So I was blessed. So when I came to Santa Barbara, I was invited by Dr. Arnett to come practice with him. And his practice was at that time limited to orthognathic surgery. And he had already published his articles in, I believe, 1993 about measuring the face. And so a lot of what he was doing was really in front of everybody else doing orthognathic surgery to get a good looking face. Because even up until that point, you talk about airway being important. Even at that point, faces weren't important. What was important was putting teeth together, like dentures, and then being done with it. So people were doing jaw surgeries and ending up with goofy faces, and that, people still do that. But so what was really interesting and intriguing is I bring with me this airway background from residency and from all the studies and research that I'd been doing. And come to find out, when you treat the face the way that you're supposed to make a good face, the airway comes along for the ride correctly. And so even going back, if you investigate some of these early studies by Powell and Riley and Hochbahn and Princell and these early maxillomandibular advancement papers, most of the time they were coming straight forward and in the face, so they'd advance jaws, 10 millimeters, boom, and solve the airway problem, or would they? And then you find out that, well, sometimes they're making bad faces, sometimes they're creating lip incompetence and mouth breathers, even though they're solving, say, a sleep apnea problem. So all this kind of came together at the same time, and it's just been exciting to, over the years, kind of put the exclamation point at the end of the idea that the face and the airway and the bite all go together. And if you treat all of them at the same time, and that's your goal, the outcomes are far better than just, say, focusing on one thing.
And do you find there are a good percentage of oral maxillofacial surgeons that are just thinking from an aesthetic or an occlusion perspective and not thinking about airway, where there might be retractive techniques occurring? Or do you ever get patients who might need a surgery done again because of that portion wasn't addressed, the airway component wasn't addressed?
Sure. I mean, yeah, a portion of my practice is revision surgeries, and the most common reasons for revision are usually inaccuracy, but also, failure to address the issues. Like I said, you could have patients where the airways open up, but they are now lip incompetent, and they come in and they're like, I can't get my lips together. This is really a disaster. But it wasn't a thought process. So the idea of putting the lips together with the surgery is not often thought of, for example. As far as airway components, I don't know. I think now people understand a little bit more, but back maybe a few years even, I don't know, maybe longer. It's hard to keep track of how long is long. I think the 80s were yesterday. So, but the idea is that even back then, people were setting back mandibles because they thought they were too big and ignoring the fact that the maxilla had a lot of room to come forward. And honestly, that's something that was taught to me by Arnett, because his analysis showed that was the case, that in the United States, at least, true mandibular hyperplasia is very, very rare. So, but see, that's not the way things were often treated. They were okay doing sagittal osteotomies and doing setbacks, so much so that they create a surgery to do that. So they create the intraoral vertical ramus osteotomy to do these big setbacks, and it's like, well, we don't have to do setbacks. And in fact, I would say in 21 years, the amount of setbacks that I've done are few and far between. So
That's interesting.
Listen, you can find fault in every profession and all across the board. I think the take-home message is if you treat all the systems, that's why, like what Becca said about slick, was that you put the teeth in the bone, you get a healthy result, but that demands a maxilla that's wider, right? Putting the lower teeth in the bone demands a wider maxilla. So each step of the way, you identify the healthy result or the healthy outcome, and it solves all these other problems and also exposes other diagnoses that maybe we might have missed. So if you go for the health as opposed to some norm or some idea, and I'm sorry to talk so much, but there's even this problem in quote airway dentistry. For example, this whole discussion about intermolar width. You can take somebody to a place of health in the face and measure the intermolar width and not meet what is considered correct or normal, but that's okay. It's like that's a study, that's a number. It's not a person nor a state of being. That's health. So we can, even in the airway business, quote unquote, get trapped by some of these ideas, some of these dogmas. I think dogma is what kills us. Speaking of dogs.
Can I piggyback off of that?
No, do it.
Well, and so to follow up with what Mike was saying, I think a lot of what we both look for is dysfunction. And so it's not just how do the teeth fit together, but it's how does the system work in harmony. And so when the bones are in the wrong place, the teeth are often in the wrong place, and the soft tissue is what compensates. And the compensation can be in the tongue, in the lips, in the cheeks, in the swallow, in the speech. It can lead to TMJ problems. It can lead to gummy smiles. It can lead to a whole host of other compensation patterns. And that's where our patients become symptomatic. And so our job as dental professionals is identifying the dysfunction and then understanding from a treatment planning perspective how to help unravel that, how to treat the system and get the system to health. And so expansion is one tool, but it's not a panacea. And so to follow up on Mike's comment, you can have, a deficient, let's say a deficient intermolar width, but the jaws are in the right place, patient functions well and in a healthy way. You can have the reverse where, let's say both jaws are back and down and it's wide. It can be wider than your ideal intermolar width, but if it's way back, that you still have a deficient airway and you might have lip incompetence. So transverse is not the only dimension that we have to look at. And so I'm glad, so that just piggybacking off of that.
Yeah, it's so true. So looking at all dimensions and also looking at function, right? You know, I'm a myofunctional therapist, so we see a lot of patients who maybe the skeletal component is corrected with orthodontics or maybe surgery, but we also want to follow up and fix function because we see a lot of patients who might relapse when the muscles might overpower the bone, depending on how the patient's functioning, whether they're continuing to be mouth breathers or simply expanding or even doing treatment to resolve a medical cause of mouth breathing. The tongue doesn't know, like, okay, now I'm going to go up, rest gently, suction to the palate, lips closed. Like, we need to rehabilitate muscles. So I like that concept of looking at all dimensions and a holistic perspective, looking at functioning as well. I'm wondering, how did you both start working together? How do you guys know each other, and how did you start teaming up and working together?
Me?
Sure.
We both gave a lecture at a Spear symposium, and I think we both were. Mike's was "Shut Your Mouth, Save Your Life." What was the name of your lecture?
Yeah, that might have been it.
That sounds like, yeah.
And I think mine was talking about setting up the face with the parts and the pieces in the right place. I think we cited similar literature, and we just started talking.
And so, and you guys both developed a course together. Is that correct? That it's the two of you. So it's called Healthy Growth, Healthy Faces. When did that course, when did you develop that, Dr. Gunson?
Oh, again, years, I don't know. It's been
Year,
4 years, 3 or 4.
okay, because I've seen that advertised like 4
Yeah.
years. Okay. So what I saw online about the course is that you're talking about how exactly what we're talking about right now. The face is a balance system, and you write the system includes jaws, joints, teeth, periodontium, lips, cheeks, tongue, and each part of the system influences another. The way we breathe, speak, and chew influences skeletal growth. Unhealthy growth patterns can lead to future breakdown of the system early and late in life. And it is so important to know and recognize that dysfunction early in life will change that growth pattern of the entire face. Dr. Baca, what would you say are some red flags in your pediatric patients that you might see, or things parents can be aware of that are signs of dysfunction and poor growth patterns?
And one that's pretty easy to spot is crowding. Crowding is a sign that the jaws are too small. And historically, the orthodontic paradigm was to wait until all the teeth came in, take out the teeth that didn't fit, and line up what you have. And so the paradigm shift really is to identify the why and to come up with a proper diagnosis. And if the true diagnosis is deficient jaws, then to grow and develop them at an early age. And that might be width, and it might be also AP. And then with that comes function. And I'm sure, Nicole, you see this in your practice as well. But if you have a child and their parents are telling you they mouth breathe every night, when they get a cold, they're just toasted for weeks. You look in their x-ray, they've got enlarged adenoids and tonsils, history of ear tubes, waking through the night. Maybe there's bedwetting, maybe not. But the parents, they see the crowding. They don't know that an orthodontist has anything to do with adenoids and tonsils. They don't know that, why is the orthodontist asking me about bedwetting or snoring? I didn't know that it was unusual that my kid was waking me through the night and crawling into bed with me. That's just the norm. I thought that that was age appropriate for an 8-year-old. And so having these conversations, and at the end of the day, we're still doing orthodontics, but it's expanding as needed. It's working with ENTs, it's working with allergists, working with sleep medicine, and then ultimately working with myofunctional therapy.
And what kinds of questions do you ask parents? So, as an orthodontist, initial or maybe appointments where they come in throughout the course of treatment, what types of airway questions are you asking? Or are there specific screening measures you use when you get a new orthodontic patient?
Yeah, we use Shervin's Pediatric Sleep Questionnaire because it's an easy one. It has, I think it's 12 questions. Anyone that's listening can download it. My understanding of the history with this paper, or where the questionnaire came from, it was Dr. Shervin, I believe, is in Michigan, and it was about access to care. And he said there's a huge unserved population of pediatric patients that have sleep apnea. They might not have access to a sleep study. Can we identify certain questions that if it's a yes, it has a high correlation with a positive sleep study? And so it really opens up a conversation for us to have with the parents, because it's questions that it's answers you might not necessarily know to talk to the orthodontist about. And then also Ferris 6 is a great screening tool, also available to download on the internet. So I think there's a number of great screening tools out there. We have it as part of our new patient paperwork. Everybody under 18 fills it out at the beginning, and then they fill it out at the end. And I think filling it out at the end is of equal importance, because we want to know if there were problems we identified early on, have we addressed them in our outcome?
And do you find oftentimes with orthodontic treatment that these questionnaires, the results are getting a lot better in terms of airway? And are you having to refer a lot to other practitioners like ENT or allergy or myofunctional therapy?
Yes and yes. Yes, symptoms get better. Yes, we refer.
Yeah, that sort of team or interdisciplinary approach like we talk about. So Dr. Gunson, I'm curious, I think a lot of us hear about like, okay, MMA surgery, but what other surgeries does an oral maxillofacial surgeon do? What types of surgeries? There's probably tons, but can you name a few ones beyond like just a double jaw surgery for helping airway issues?
No, I'm not familiar with those. No, I'm just
Do you happen to know any other?
yeah, I was going to say, well, my practice is limited to orthognathic surgery, period. But the scope of a oral maxillofacial surgeon is just that. It's oral and maxillo, meaning the bones of the face, and facial. So it's pretty much anything from here to here and from here to here. So the common things that people do are take out teeth, take out third molars, place dental implants, various places, tumor resections and tumor reconstructions, jaw surgery, frenectomies, vestibuloplasties, facial cosmetics. Yeah, a lot of TMJ. Wow, I left that out because trying not to remember TMJ issues, but no, manage the temporomandibular joint, both surgically or medically, things like that.
Okay. And like we always talk about early intervention, getting to these kids early, but in terms of jaw surgery, what's the youngest age that you might do double jaw advancement or a surgery like that?
Yeah, that's a good question. And it depends who you ask. There are people in the world who might recommend intervening prior to growth cessation. I know there are some that have written books and lecture on such things. In fact, it was back in the early 2000s that Christian 𝐃𝐈𝐒𝐂𝐋𝐀 of Stanford, so the father of sleep medicine pretty much, was finding that we needed to intervene sooner because kids and young adults who were not being treated were having neurological damage that was irreversible in terms of airway compromise and problems. So he was becoming a huge proponent of early intervention towards the end of his life. And he called the office and asked us that same question: how early would you be comfortable moving jaws to help these kids out? And the answer is there's a give and take. So first off, the jaw surgery relies on anatomical, not just cuts, but splits. The bones have to be able to separate correctly from themselves. And as you know, in young children, the bones have not really become dense and they don't quite split as they ought to, sometimes if they're too immature. So it complicates the surgery a little bit to have immature bones. But I would say more importantly, the joints are not done cooking either, or maturing or developing. And jaw surgery, especially advancements, put a certain amount of stress and strain on the jaw joints. And if that stress and strain is transmitted to a jaw joint that hasn't matured, you run the risk of losing the joint under pressure because it's not done maturing. So the risks kind of go up when you're treating people who haven't finished growing. The kinds of interventions that you can perform on kids who are still growing are orthopedic in nature. So you want to promote bone growth by putting traction on the jaws in different locations and in different fashions. And that's, the realm usually of the orthodontist, but the oral surgeon can help out, placing TADs or plates and applying forces both anterior, posterior, and vertical and transverse to help, guide the bones. But there are only certain directions that of growth or orthopedic movements that are reliable. Other dimensions and directions are less reliable. So it's tough. But as for myself, to answer your question with less words, I wait for the jaw joints to be mature. And that can be assessed on a cone beam CT, looking for the cortical outline of the condyle of the mandible. When it has a complete cortical outline, it's done growing. And then that's when I find it safe to do jaw surgery.
And is there kind of a typical age range that jaw joints done growing or maturing?
There's so much that depends on that.
Okay.
Females 16, males 17,
Okay.
and even then that's a low percentage of being done. So each case you got to look at the joint and make sure, because the male who's got a very small maxilla and a robustly growing mandible, that they tend to take longer to mature. And I've had patients that take out to 20 years old or 21 years old for those condyles to stop growing.
Mhm.
So that's
So
just depends.
So for like a child with sleep apnea who's definitely retrusive, who's gonna need double jaw surgery, what do you tend to recommend, or what do you do during that growing period before they're old enough to be able to have jaw surgery? Is it sometimes put them on a CPAP, or you just do as much orthodontic treatment as possible until they get to the age where they're able to be able to have a jaw surgery, Dr. Gunson?
Yeah, I think Becca should feel that
Okay.
way.
Nicole, I think it's a delicate balance with financial costs to the families as well as time, and avoiding burnout and not ignoring symptoms. And so I think it's every patient dependent. If they have relatively straight teeth, but they're bimax retrusive, it's probably CPAP or oral appliance to get them through high school until the growth is done. And then when we put braces on, it's sort of a one-time thing. If there's upper crowding, maybe it's limited alignment for high school and then moving into surgery. If they're maxillary deficient, we can sometimes get the maxilla to widen and come forward with today's MARPI designs. So there are some things we can do with growing teenagers that we couldn't do previously, and that's evolving. And so it really depends.
Yeah, I do want to, I'll throw something in. So sleep apnea and airway disturbance, and those are kind of two different things, but we lump them together. But in kids and in adults, there are three categories or three areas that cause this kind of airway problem to occur. One's the hard tissues, one's the soft tissues, and the other is the neurological tissues. So hard tissues is what like we've been talking about, is like, how do you move the bones, how do you move the teeth? But we can't forget the soft tissues of the face, and this is also where intervention is easiest to address in the young person as they're growing. So you can do orthopedic stuff for the hard things, but for the soft things, what are we talking about? Well, we're talking about tonsils and adenoids, we're talking about tongue ties, we're talking about myofunctional therapy, but most importantly, and especially in the United States, we're talking about obesity. So we cannot forget that the number one cure for people that have sleep apnea is solving the obesity problem. And that often gets forgotten in these young kids and adults for that matter. You know, I have a lot of patients that show up at my office for jaw surgery, and sure, they might have a minor facial problem, but they got a BMI of 40, like they're 280 and 5'8", and it's like, you would be surprised how well you would feel if you lost 100 pounds. And nowadays with these, well, so far fantastic, we'll see how the side effects pan out, but these GLP-1 agonists that are helping people to lose massive amounts of weight, but doing it in a way that controls the inflammatory issues, the diabetic issues, the insulin resistance issues, you know, there's a lot of help. So we can't forget the obesity. And you know, there's something to be said too about, you know, strengthening the tissues. That was another like rah for Dr. 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐿𝐿𝐿 before he passed away. Is, I mean, he literally was screaming for myofunctional therapists to be involved in every case before he died.
Yes, whenever I lecture, I always review a lot of his research and give credit to him because he was one of the hugest proponents of myofunctional therapy and the role of the tongue in the pathogenesis of sleep apnea. He really participated in a lot of the research studies and got that initial push out there. So I always give credit to him for, you know, amazing research studies on that. I want to talk a little bit about the obesity thing. I just recently did an interview with Dr. Andrew Cohen, and he said, make sure I say hi to both of you from him. He appreciates all that you both do. He's like, definitely tell them I say hi. And we talked a lot about the metabolic component and how he really wants patients to be aware. You know, we talk about skeletal component, dental component, soft tissue, but a lot of people do miss that metabolic aspect of health and breathing, and how a lot of our patients with airway compromise, sleep disordered breathing on the full spectrum, all the way to obstructive sleep apnea, have high systemic inflammation. And that inflammatory component is further making the airway issue worse. And he talked a lot about our diet and getting glucose monitoring to see what you're eating and to be able to move and take walks and watch those sugar spikes, because what he saw is when his sugar went up and he didn't control it by exercising after, those were the nights he had the worst sleep apnea, the worst snoring. And it's a really important component for us to let our patients become aware of. Any one of our treatments might not necessarily cure this issue, but there are multifaceted aspects.
Yes, and that's perfect because, I mean, you're touching on so many topics there. Because inflammation doesn't just come also from diet. You have patients who have autoimmune diseases that show up in young kids. One of the major ones that you'll see in the teenagers is like Hashimoto's thyroiditis, which causes both inflammatory problems and arthritic problems, which can be a double whammy to the jaw as well as to the airway. Then you have, on the opposite side of things, you have the perimenopausal and postmenopausal female who's in an hyperinflammatory state. And then that, you know, that's putting them, and we know they're at higher risk for sleep apnea and respiratory disturbance problems. So you have that inflammatory side of things. And then the other issue is you have connective tissue problems. So there's an underdiagnosis of patients who have hypermobilities, syndromes, Ehlers-Danlos and Marfan syndrome. And these go undiagnosed, and yet these people are highly flexible, highly stretchy. I just had a consult today with a woman who has astigmatism, scoliosis. She's 6 foot. She's 200 pounds. She can wrap her hand around her wrist. Her fingers, are like this long. And she's in and out of the doctor's offices, and not a single person identified her as being Marfanoid. But she has all the face of it. Her soft palate was like that long, and she's like, well, what's wrong with me? I've got all these things going on. Well, yeah, you have a craniofacial problem, and we can solve that, but you also have these soft tissue problems. So inflammation, soft tissue, like that's why, and I just want to put this in as a plug, like a lot of times with the expansion and the advancements, we're pushing envelopes of what things should be. We are over advancing sometimes, and we are over expanding a lot of times. And if you can't correct the problem, the airway problem, by putting the parts in the right place, both functionally and aesthetically, then your problem is not a bone problem. You're dealing with inflammatory problems, you're dealing with soft tissue problems. And yeah, okay, so people are like, well, but we can overcome those if we push a little further. But as soon as you start moving into realms outside the envelope, you're creating other problems. And so we just need to respect the whole system. And I think it's just a failure to diagnose broadly, like you said, and like Becca said.
Mm-hmm. Yeah, can I add to that too? Just from the when we were down in San Francisco at the World Sleep Society meeting, there was a lot of talk about melatonin levels, and exposure to sunlight was something that I talked to some people about. And you have these high school kids or middle school kids on their screens late at night and maybe not getting outside, not getting daylight, and that changes melatonin cycles. We don't talk about that with our patients. And iron levels, and low iron levels being attributed to restless sleep in children, which might not necessarily be picked up as restless leg, and they wouldn't necessarily qualify as sleep apnea, but they are tired. They're tired during the day. They're not sleeping well, and it's not a craniofacial issue. It's an iron deficiency. So, like, to echo Mike, just thinking broadly.
Right, because it's not all structural. There's non-structural sleep-related components, and that's interesting. I went to that lecture talking about the restless leg syndrome. That was fascinating, and I experienced something with my child who had sleep apnea. We did all different treatments. I mean, like everything the research shows with, tonsil nano removal, tongue tie release, myofunctional therapy. He did expansion a couple times. He did MSC when he was 8 years old because the other appliance he used tipped the molar so far out that they couldn't do an RPE at that age. But in 5th grade, his teacher's like, he just can't sit still. Like, he does not stop moving. He actually is like pacing around the back of the classroom. And I talked to him about it. And he's like, well, mommy, I just have this feeling in my legs, and my legs feel really tight. And I was like, okay, sit still. Don't move. Let me just see what happens. And he's sitting in his chair, and he's like, I can't stop. It's going to my arms now. As he's trying to not move, he's like, now my arms are feeling weird. And so Dr. Gerald Simmons said, let's get his ferritin tested. And it was really low. And he was like a kid with ADHD, but like a misdiagnosis because there was an iron deficiency. So we supplemented. It takes about 3 months to see the difference. But then his teacher reported back that after we did the 3-month supplementation, he sits fine. He doesn't need to pace. He forgot about that feeling he was having. So point being, it's not always airway. There's so many other aspects we need to look at, and it's the body as a whole, that whole system. So it's really interesting. And when you just talked a little bit about the hypermobility syndromes, Dr. Gunson, I always wonder, how are those patients how do we treat them differently when it's maybe a tongue tie release or jaw surgery, or Dr. Backow orthodontic treatment like MARPE? Is there a different way you treat patients with Ehlers-Danlos syndrome or other hypermobility syndromes? Yep.
Yeah, I mean, obviously that you can't change the nature of the connective tissue, though you can approach things sometimes for tightening the tissues, etc. But the main thing that you need to do in these patients is approach them from an informed consent standpoint. It's like, how able are you to address their airway problems using a hard tissue approach? No, they're not going to respond as robustly to the treatments as people that don't have connective tissue disorders, so that has to be discussed. Secondly, they're prone for more complications, so healing problems of soft tissue and bone. And they all have high anxiety usually, as well as something called interoception, where they are highly sensitive to anything that touches themselves or from inside their body. And so those are the hard patients to work with, because they always feel like their bite's off, or they feel the scar from any incision, or they feel the movements of the jaw. Like just today, well, actually it was same patient with Marfan syndrome had expansion with and she's like, this muscle back in here, back behind my last tooth in my mouth, has like been going off ever since my expansion. Will that get better when I have jaw surgery? I mean, that is a typical question of a connective tissue disorder patient, and the answer is, I don't know. But then you point out that this is part of your superpower. You have the superpower of hypersensitivity. You're going to feel your muscles do things inside your body that maybe seem abnormal, but in the end, it's just your body adapting to the movements that we're making. It's not necessarily pathological, but they learn to associate a lot of these sensations with pathology. So
That's interesting. I never knew that. So it's just a characteristic of that type of disorder is that they feel things more. It's
yes.
interesting. I didn't know that. How about for like MARPE or other types of expansion, even in a younger child, Dr. Backow, does that your orthodontic treatment change if somebody has hypermobility syndrome?
I think, like Mike said, it's a lot of informed consent. I think sometimes we've had patients with connective tissue disorders that have responded in ways that I wouldn't have otherwise predicted. And so going through our typical informed consent, but then following that up by saying, we are going to watch this very carefully. We're going to go very slowly, because I can't predict how your body will respond. I think it's also asking a lot of questions, and Mike, I'm sure you asked these too, about previous procedures and wound healing, because every patient with a connective tissue disorder, they respond differently. And they often know that about themselves. They say, oh yes, I've, and some do fine, and some don't, and we abort. And as long as we tell them up front, then we've been very honest with them. And I've had to abort before. So we do our best, but we've told them ahead of time.
That informed consent piece. What about, okay, so we talk about early treatment, and Dr. Backow, what is some of the early treatments that you might do orthodontically for a child? What might be the youngest age that you might start doing orthodontic treatment on a child? And then also, when is sometimes early treatment not good? When do you choose to wait to begin treatment? Sorry, I loaded on so many questions.
Yeah. Well, so I think if we back up and we talk about intervention can take on we can intervene in a lot of ways. And so as soon as we identify a problem, it might be as simple as telling the parent of the 3-year-old, it's not healthy to continue using a pacifier past, at age 3, or we need to really address the digit sucking habit. It might be referring to the allergist or referring to the ENT early. It might be recognizing that there's a pet dander allergy and maybe not sleeping with the family pet. Intervention can take on a lot of, it can look different, and it doesn't have to be, and it can be myofunctional therapy. It can be OT and myofunctional therapy. It can be craniosacral therapy. It can be a number of ways to get these kids to breathe with their lips together, tongue up, quiet nasal breathing. And if that's our goal, and really thinking about the system, then intervention looks different. For when it comes to orthodontic intervention, I think more about patient maturation than I think about chronologic age. And many of the listeners here have probably seen 5-year-olds that talk to you like they're adults. and 9-year-olds that cry through the entire procedure. And so picking the child that's ready. And so when we meet kids under the age of 5, our first visit is sort of a high five meet and greet, and just how comfortable are they with us looking in their mouth? Can they handle getting photos taken of their teeth? Can they handle an iTero scan or a intraoral scan? How do they do sitting in the CBCT? And so once we kind of take them through a lot of steps to see how ready they are. And they might not be ready. And if they're not, then we bring them back in 6 months and we keep checking in with them. It can be trying a removable appliance. There's a lot of removable stock appliances out there. But I try to be I try to be careful with them, because I don't want to burn these kids out if they ultimately will really benefit from a custom appliance. When it comes to maxillary protraction, earlier is better. And so thinking about getting that upper jaw forward, if we wait till after age 8, it's a lot less predictable. So I would say class 3 tendencies, we want to get in there a little earlier than otherwise. I think other kids I've seen where we really want to be thinking a little bit earlier, when we have these significant cross bites and a lot of parafunctional habit, a lot of dysfunction. And I think that the myofunctional therapists probably see this as well. They don't have a place to put their tongue. They don't know what to do with speech and swallow, and they're just sliding all around because they don't have a place to bite and chew. And so we think about condylar growth at these early ages. We think about motor function, speech and swallow, lips together. We're missing out on all of this developmental milestones when it comes to speech, swallow, and chewing. And so really thinking, I think conventional orthodontics waited until the first molars come in, and I don't know that we need to do that anymore.
So you might do expansion treatments on what might be the youngest age that you might expand.
Honestly, it's really if they can sit in the chair. So really trying to, and so if they're otherwise asymptomatic, there's no other issues and they have crowding, maybe we wait. If they're symptomatic, we might intervene. So I don't know that I have a number other than just really trying to pair the right treatment plan with the right patient.
Okay. And then I'm going to jump around because I also know you talked about a little bit about MARPI and how the maxilla can come forward. And I know people have asked, we're doing transverse expansion with MARPI, but there is some AP growth. Can you talk about that?
Yeah. Well, so rather than saying maxilla, I think today we can say the nasomaxillary complex. So really thinking about this bony system. So the sutures are here, 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 and in the middle. And so when we expand the maxilla, we're opening all of the sutures. And so in a patient that's otherwise maxillary retrognathic, we can today bring that, as we widen, we can bring it forward. I don't know if we know the limits yet. We've seen some pretty incredible forward changes with our patients, and we're really pushing the envelope, so to speak, with the age as well. And so I think we're still understanding our limitations, but it's been exciting.
So is that just by nature of using MARPI, the nasal maxillary complex comes forward, or is it with like a reverse pull?
Sorry, no, with a reverse pull headgear, yeah.
Okay. So doing MARPI alone, is there any forward growth?
We think about like a millimeter. I think it comes forward a little bit.
A little bit.
I think you also create space in between the teeth. So there's some forward movement of the dentoalveolar complex, the teeth. So yeah, things come forward a little bit.
Okay. And before MMA surgery, is it beneficial to do MARPI first and then do a double jaw surgery, or is there a consensus on this?
I'm turning that over to Mike.
No, he says no. Okay.
So yeah, I get asked that question a lot by patients and also by orthodontists, like, what do you want me to do? And the answer is, So I can expand a maxilla with orthognathic surgery. I can do a multi-segment Lefort 1 maxillary procedure. I can expand it. The MARPIes can expand. You have to understand the difference between them, though. My expansion can be differential, meaning I can make the upper jaw fit the lower jaw and expand the front 2 to 5 and the back, 9 to 10, or any variation of that. MARPIes expand front and back, 4, 5, 6. It's the same. It's similar expansion. But you do have to recognize that most jaws don't grow that way. They don't grow like this. And so what's the dilemma? Like, what's the choice to be made? The choice really is about what Rebecca said. Becca said that if there's crowding, that's a small jaw. So if you want the teeth to fit, you make a bigger jaw so the teeth can fit. How does that affect me? If you try to solve a small jaw problem with a full complement of teeth by arranging the teeth correctly, you're going to get the front teeth to flare forward.
And the back teeth.
And so those front teeth are going to push out this way, and that's going to provide lip support here without actually providing bony support above it. So when I advance the jaw, I'm going to reach the limit of what the lip can tolerate faster if those teeth are sitting way out underneath the bone, without reaching the limit for the bone advancement here. So I'm going to more quickly create a disability with my advancement than if we had expanded and brought those front teeth back underneath the bone where they belong prior to the surgery. And that's accomplished by making the jaws their proper size and shape and putting the teeth in the bone periodontally where they should be. So expanding before surgery is a question of crowding and putting the teeth in the right position. It's also a question of, do we need to intervene sooner because they're young and not breathing? And the answer is, yeah, go right ahead and do it. What I don't want to have happen, though, is I don't want overexpansion. I don't want overzealous upper jaw expansion to the point that now I can't even fit the arches together because the upper jaw is broader than the lower jaw or the lower teeth, and there's no more room to upright the lower teeth. And people are like, well, we'll just do periosurgery and we'll do corticotomies. It's not enough. It's not enough to get those lower teeth out to fit an overexpanded upper. And then when they overexpand the upper, let's say you get 5-8 millimeters of diastema. Well, now you have to take those front teeth and fill that space. And when that happens, a lot of orthodontists go from an arch that looks like this in the upper jaw to an arch that looks like this. So it's flat across the front here, and it's aesthetically a nightmare. And now you're putting teeth underneath the bone or behind the bone. So I can't support the lip as well as I'm supporting then this bony complex. So it's complicated. And there are a lot of side effects to doing it the wrong way. So my answer is MARPI before jaw surgery to solve crowding problems and to allow uprighting of the lower teeth. If that doesn't exist and you're just dealing with a shape problem, I can shape it at surgery. That's not a problem.
Okay. What if there's no crowding, but teeth are compensated to fit together? Is MARPI suggested so then you can upright the teeth and then doing that before jaw surgery, or only if there's crowding?
Well, it's the same. So
Okay.
don't think of crowding as teeth not fitting in the arch.
Okay.
Think of crowding as the teeth not fitting in the bone that they've been given.
Got it.
Right? So if the teeth are straight, but they're pushed out and leaning out from the bone, that's crowding.
Okay.
Right? Not crooked.
Got it. Thank you for clarifying that.
Yeah, and that's fine. If there's crowding, meaning the teeth are flared out like you're describing, then by all means expand and pull the teeth back into the periodontium. I just love that you started this whole conversation, Becca, quoting Slick about putting the teeth in the bone. And how long ago was that? I mean, it's like,
he was arguing from the podium in the 60s and 70s.
Right.
Everyone thought it was here, just terrible.
And we're still. Okay.
Oh, I was just gonna, and so I think to piggyback off what Mike was saying, I think, and what you were maybe alluding to, Nicole, I think sometimes when we're decompensating for surgery, we upright the lower and we have to tuck the top in. And it ends up looking like we unmask what otherwise was a transverse discrepancy. And that is okay because we're going to surgically widen the upper jaw. And in fact, if we as orthodontists don't decompensate, then we limit what our surgeons can do for us.
Okay. Okay, that makes sense. And what about Dr. Bacow? Do you ever find that patients who you do a MARPE procedure on don't need jaw surgery after because they have symptom relief? So maybe someone who has airway problems, they feel better, they breathe better, sleep better, that they don't even pursue the jaw surgery route after MARPE?
I think it's a question of diagnosis. If the diagnosis is a transverse discrepancy only, then an appropriate treatment plan is MARPE. If the diagnosis is, for example, maxillomandibular deficiency, vertical maxillary excess, long lower facial third lip incompetence, you can't expand your way out of a vertical problem. And so even if MARPE will help that patient breathe better, our treatment doesn't end with expansion. And so, to Mike's point, sometimes it's most efficient to plan for the double jaw surgery.
Just plan for it.
I think also when you have a deficient mandible, especially, and I get these questions a lot, just widening the upper jaw won't fix it. And so I have a lot of, and Mike says this too, like what is it that we're trying to address in our treatment plan? If we do a MARPE, let's say in a patient that's going to have the lower jaw advanced, as the orthodontist, unless I'm taking tons of records throughout, I'm guessing what is the ideal width when the lower jaw comes forward. I think it's easier, and Mike correct me, if we decompensate the teeth and then Mike can get the upper jaw to meet the lower jaw when he has everything ideally positioned.
Well, does everybody who has a transverse deficiency probably have maxillary and mandibular protrusion? Is it possible to be narrow but have your jaws grown forward correctly?
I'll let
Is
Mike
that
take that one.
a random question? I'm just thinking, like, wouldn't you have both in most cases?
I think the odds are that when there's hypoplasia, it's global. I mean, that's the answer, right?
Yeah.
However, having said that, I've seen plenty of patients that get beautiful aesthetic results, have beautiful airways, and only need expansion.
Okay.
So it happens. But I think it's fair to make the comment that most likely hypoplasia of the skeleton is global.
Okay. And what does it mean when the dental midlines don't match? Is that a problem with the upper jaw or the lower jaw? I never understood or is that not a universal thing? It depends on case by case.
There's a lot of reasons.
Okay.
Sometimes it's a two-size discrepancy, undersized lateral incisors. Sometimes it's unilateral two-size discrepancy that's been otherwise undiagnosed or untreated, or it could be early loss of a premolar, or some sort of other dental reason why there's upper midline shift. And then lower midline shift, I would say, and Mike, I might turn this over to you, is maybe a condylar issue.
How do you know if it's upper or lower? Is it just upper should match like the center of the face? Like, how do you know which one is off?
Yeah, you have to establish the center of the face, the whole face. So that's a whole, 30-minute discussion about how to do that.
Okay.
But you establish the middle of the face, the whole face, and then you assess where the middle of the teeth are. This is so great. I had a week full of consultations and really, really interesting situation where the lower jaw was the problem. The right or the left side of the jaw was smaller than the right, and so there was a shift this way. All the lower teeth had been made, to fit the other way. And so you have these lower posterior teeth that are going towards the tongue, which creates less space. So in the anterior, the whole anterior left side was crowded, right? So the teeth were out of position and crowded. And then the left side looked good because it was all uprighted and pushed out this way. So there was more space to the arch on the right side. So it's kind of fun doing consults because you're like Sherlock Holmes trying to figure out things like that. But mandibular asymmetry is almost always, I mean, it can be hemimandibular asymmetry, so half the jaw is not growing the way that it should. It can be condylar, and a lot of these issues can be also developmental and not necessarily genetic. And I think this is where Becca sees them a lot, is you have teeth that are coming in correctly because of growth problems, say in the maxilla. Then all of a sudden the lower jaw has to posture to one side to fit the problems going on in the upper. And that's a functional shift, but a functional shift over time because of compression of the joints will turn into a skeletal asymmetry. So those joints under compression will undergo resorptive changes and deposition changes to provide a change. So that's, again, really important to identify these functional shifts early before the condyles respond to that.
Interesting. And when there's a midline shift, do we typically see a little bit of facial asymmetry or
Sure.
not in all cases?
Depends.
Okay.
Yeah, I mean, there's two kinds of asymmetry too. There's the at-rest asymmetry. If the jaw is over here and the face is relaxed, then the lips are like this and the face has asymmetry to it. Mm-hmm. But there's also functional asymmetry. So if the jaw's off or a little bit off, or if there's a functional component, if the teeth are in the wrong place and the lower lip has to move off to the side, then people will hold their lips into an asymmetric position or pull like that.
Okay.
Yeah, it just depends. There are some people that are really good at hiding their asymmetries. I've had patients with 5, 6, 7 millimeters of asymmetry, and you wouldn't know it until they let their lips come apart.
So interesting. As a speech pathologist, it's so interesting to me because you watch people speak and kind of knowing about this dental skeletal component, because not all speech therapists have, sort of insight in this area, or knowing about the functional component, watching people speak and just looking at different movements and compensations. It's really interesting. And just thinking like, how are the teeth lined up? What's going on with the jaws? Why is the person's jaw shifting when they say particular speech sounds? Because it's obviously all related. So it's just fascinating to me. Couple things before we wrap up, because I know we're going over on time, but I do want to talk about your article, Dr. Bacow, on the impact of rapid palatal expansion on the size of adenoids and tonsils. Can you talk about the results of that study?
Sure. Well, I was, Dr. Yoon and I were talking during the pandemic, and I said, I'm seeing adenoids and tonsils shrink after expansion. Are you seeing this too? And she said, I'm seeing it too. I said, has anyone published on this? She said, I don't think anyone's published on this. And she has this amazing data set because she had these symptomatic patients that came in pre-pandemic, had all their records taken, and then didn't go through with treatment because of the pandemic shutdown, came back a year later, had another another CBCT. So we have this untreated sample of patients that had enlarged adenoids and tonsils that received no treatment. And so then we were able to pull our data from our practices and show that, I don't have the paper in front of me, but I think it's 97% of patients had some level of shrinkage, up to 75% of tonsillar shrinkage with expansion. And so what we tell our patients is, but some was only 10%. And so being really honest with people, we think it will shrink. By how much, I don't know. There were some non-responders, but overwhelmingly the patients in our paper had a very positive response. There was another paper from Dr. Guilleminault and the team at Stanford, and they said, if we have a child with enlarged adenoids and tonsils and they need expansion, the first question is, does it matter which intervention comes first, and can we get away with one or the other? And so they did a sleep study One group had expansion, one group had tonsil and adenoidectomy. Then they did another sleep study, then they swapped. And what they showed in that study was that with one intervention, they saw improvement, but not 100%. When they swapped and every child had both interventions, they saw 100% improvement. And so what I tell families is if we expand, we're expanding because we need to do it from a dental, craniofacial and dental reasons. That's why we're recommending it. We're not recommending it to try to shrink your adenoids and tonsils. If that happens, that's really awesome, but you still might need to see the ENT.
That makes perfect sense. And we talk about monotherapy is usually not a cure or treatment for these airway issues. There's usually multiple components that need to be treated. And it depends on what order a parent might want to go. When there's already enlarged tonsils and adenoids, do they want to see if the expansion will help to maybe avoid surgery, or is the sleep breathing issue so severe they're not able to get any nasal breathing, that tongue is just pushed so far forward that maybe they need to open up the airway medically first?
Yes, and so on that note, if we have a patient that comes in and they have diagnosed apnea and or parents have witnessed cessation of breathing, they're waking through the night, we look radiographically, adenoids and tonsils are enlarged, we tell them ENT first. That is the fastest, most well-documented way to get a child to sleep better. And so we let's get sleep on track, then let's start expansion.
Yep. Then let's expand. Then let's correct function, rehabilitate the muscles, get the tongue up, lips closed, and seal the deal. It's a multiple aspects. So a couple quick things. I'd love to hear about your course, the Healthy Faces course, how often that occurs, where it is, like talk about that. And then also the upcoming first MARPE course that you both are faculty on. So Dr. Gunson, do you want to talk about the Healthy Faces course that you guys do?
Sure, love to. A lot of fun. So it takes
And this
place.
whole chocolate cake thing, I see people wearing
Oh,
t-shirts about that.
that's just that's our silliness. But the course is in Kirkland, Washington, so right on the lake outside of Seattle. It's beautiful, absolutely just amazing at a perfect time of year. So location wise, it's got all that. The next thing is who comes, and anybody really. We've had SLPs, myofunctional therapists, sleep physicians, dentists, orthodontists, jaw surgeons, ENT, sleep physicians. I mean, the hygienists, assistants, etc. So it's been that's really cool because it's not just sit and listen the whole time. I mean, people obviously sit and listen, but there's a lot of discussion that happens and a lot of sharing of experience. So people will chime in. There's a lot of time for questions and interaction. The reason the course does so well with such an interdisciplinary team is because what we're covering is, number one, Becca talks about the pathology of growth in kids and what that results in from all aspects, from soft tissue to hard tissue, and where the teeth end up, where the bones end up, what's the dysfunction, and the breathing problems. And then we go and talk about, well, all those compensations then morph into what happens in adulthood. And what's that? How does the face break down? What are the cosmetic, aesthetic components of facial breakdown? What's the TMJ components of facial breakdown? How does that happen as a result of poor growth? So we talk about all the pathology that comes from bad growth and how that results into the breakdown going, 30s, 40s, 50s. And then we come back and we talk about, well, okay, what if we intervene early? Great. What if we don't intervene early? Then what does it take to restore health? It's interdisciplinary, it's restorations, it's orthodontics, it's orthognathic surgery. And then, of course, how to do orthognathic surgery correctly from a face airway standpoint. And that's the chocolate cake. The chocolate cake is, the story with the chocolate cake is simply that just because you call it chocolate cake doesn't mean you want to eat it, right? So you get different kinds of chocolate cake. It's same as with orthognathic surgery or even orthodontics. You call it orthodontics, you call it orthognathic surgery, not every result is the same, and they might not be results you want, but based on proper diagnosis, based on health, achieving health, not just some random position in the face. When you treat to health, you get the chocolate cake you want to eat. So
Clearly proper
really
diagnosis.
fun 3-day intensive information course. Love it.
And it sounds like it's appropriate for therapists, dentists, anybody who works with any age group too, because we're going from pediatric to adult and kind of looping back how you can work with all ages for
Anybody
treatment.
that's involved in care of the face. I mean,
Yeah.
honestly.
Okay. That's amazing. And then also I see announced is the first ever MARPE, not course, but like conference. Could you talk about that, Dr. Bacow?
Sure. Well, a lot of us that are pushing the envelope in the MARPE space, what we're doing today is different than what we were doing 3-6 months ago. It's evolving quickly. We are all good friends and colleagues. We practice in different parts of the country, and we really wanted to have a gathering of minds. And so we put together this one-day symposium, and we'll talk about the evolution of the MARPE design, different ways to intervene in terms of surgical, non-surgical, appliance design. And we're really excited to have Mike join us as well, talking about surgical versus MARPE expansion and its impact on the airway. So it's Dr. Audrey Yoon, Mariana Evans, Jeremy Manuele, Ilya Lipkin, Richard Ting. So it's going to be a great group, a great conference. If anyone's able to make it, it's the day before the AAO conference in Philadelphia in April.
April 24th.
Sounds amazing. What's that, Dr. Gunson?
I think it's April 24th. It's Thursday,
April 24th.
Friday.
Okay. And the Healthy Faces course, when does that occur?
September in Kirkland. And the course registration is on Mike's website.
Yeah,
okay.
September 25, 26, 27.
Okay, perfect. I'll put links in the notes. Thank you both so much for all of this information. We covered so many different topics, so many questions that I had, and I really appreciate you both donating your time to help us all learn. Thank you both so much. Have a wonderful weekend, and take care. Keep doing what you do. You're helping so many people, and all the lectures you both do as well. It's just helping the field continue to blossom. So thank you.
Thank you. Thanks for the invitation.
Thank you, guys. Have a good one.
Bye, Nicole.
Bye. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much, and join us for the next one.